it already.
Okay, great, doctor. Great.
So, Dr. Alex will be giving an intro and then we'll go ahead. Is it? Yeah.
We'll have the lamp lighting, then we'll start.
Okay.
I'll share the slide, Arjit sir slides once again. Hello, am I audible, please?
Playing. Yeah, playing.
Yeah, thank you. So, Saurav, should I do it or you will do it? I'll do it, right? Better?
Yeah, definitely, doctor. You do it. Yeah, no.
Yeah, fine.
In another 2 minutes, we'll just start. Another minute, Dr. Alex is joining. He's having some trouble in networking. So just give us 1 minute.
Saurav. Hello, Saurav.
Yes, sir, Jack.
Sir is asking you to start with the lamp lighting.
Okay.
शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्जनार्दनः ज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपो नमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
So good evening to everyone. You can hear me?
Very well, sir.
Yeah. So good evening to all of you. On behalf of the Association of Healthcare Providers, I want to warmly welcome you to this fourth webinar on the ongoing series on tendinopathies. Incidentally, AHPI is a national organization with close to 20,000 hospitals in the country. And one of the things we do is advocacy, and all of you must have heard of the recent case that we filed in the Supreme Court to try and get doctors out of the consumer forum. It has been admitted, and with all your support, we look forward to proceeding and hopefully successful in this endeavor. At this time, I'd also like to place on record sincere thanks to Farmit. Farmit has been our very strong pillar of support. Thank you for supporting HPI in conducting these series and for contributing to the continued academic engagement and learnings in orthopedic practice. Over the last 6 months, we have initiated this webinar series focusing on topics of special interest to orthopedic surgeons and also to postgraduate students, addressing conditions that are commonly encountered in day-to-day orthopedic practice. Tendinopathies, as all of you know, remain one of the most frequent clinical challenges, and this series aims to bring practical insights from experienced and well-known clinicians across the country. Today's webinar focuses on tendinopathies in and around the elbow, and I'm sure all of you agree with me that this is a condition which is perhaps most commonly seen in orthopedic outpatient practice, tendinopathies around the elbow. We are privileged to have three very eminent speakers with us, Dr. Ajit Kumar from Bangalore, Dr. Satish Devdas from Madurai, and Dr. Iran from Northeast. Where Santosh will introduce them in a bit. And this webinar, as has been in the case with the earlier webinars, will be moderated by my colleague from Baptist Hospital, a well-known senior orthopedic surgeon, Dr. Santosh. As mentioned earlier and as discussed, each expert will deliver a focused presentation for about 10 minutes. This will be followed by a case discussion, and then the session will conclude with a open interactive discussion and questions from participants. We try and make sure that we try and wrap up the whole thing in about an hour to 10 minutes. We hope you'll find this session enjoyable and academically enriching. Thank you very much. And now, without much ado, let me hand it over to Dr. Santosh. Over to you, Santosh.
Your audio is mute.
Yeah, we can't hear you, Dr. Santosh. Probably your Bluetooth is off.
No, we can't hear you. So, you want to log off and try again? Saurav, any other solutions? Saurav,
Oh, you can start off the slides.
Please share the slides.
Yeah.
Am I now audible, sir?
yeah,
Now
yeah.
it's not-
Yeah.
Okay, sir.
Right.
Okay. Yeah. Okay. So we'll start with our eminent speaker, Dr. Satish, sir, who is a main heading as a vice chairman of Devdas Hospital in Madurai, and is a president of HPI chapter of Tamil Nadu, and is more interested his interests are joint replacement surgery, trauma, and arthroscopy. As you know, the elbow tendinopathy is basically a common day-to-day practice, and anyone with any kind of epidemiology or any kind of background can have that problem. So this overall, what are the causes and all will be highlighted to you, and you will understand with the next talk. Over to you, Satish, sir.
Thanks. Good evening, everyone. I first wish to thank Dr. Alex and the Association of Healthcare Providers of India for giving me this opportunity. And thanks to Pharmed for arranging this wonderful seminar. It gave us opportunity to go through the latest in this topic also. So without further ado, I'll start sharing my screen. Is my screen visible?
Yes.
Yes.
Yes, sir. Continue, sir.
Yeah.
You have to go to full screen, I think.
Is it not?
Yeah, now
yes.
yes.
Yeah. Sorry. Is it? Sorry. Thank you. So, as the previous introductions have been made, tendinopathies around the elbow are very, very common, and we see them in our day-to-day clinical practice. Almost every day, at least 2 or 3 people in our outpatient clinic. It can be for even the general public, even though it has been christened as tennis elbow or golfer's elbow. We see it in our housewives, a carpenter or a electrician. So all these people can get these tendinopathies very commonly. And also with the increasing people joining this weightlifting, gym and other things, we see more of these biceps tendinitis and triceps tendinitis, and we will see what is happening in each of these instances. Just to brush up a little bit of anatomy, laterally the structures are the common extensor origin. The medial structures include the common flexor organs. The anterior and posteriorly you have your biceps tendon, is attached to radial tuberosity, and the triceps tendon to the olecranon process. So these are the common sites of tendinopathy around the elbow. The first, the lateral epicondyle, it affects around 1 to 2% or 3% of the population annually. It involves the common extensor tendon organ, particularly the ECRB or the extensor carpi radialis brevis. Medial epicondyle is less common but clinically significant, involves the flexor pronator mass. And the triceps and biceps tendinopathy are also seen. They are less frequent, but you have to keep it in mind. Now, lateral epicondylitis was the earlier term for tennis elbow. Now it is rechristened as epicondylalgia because it's not exactly an inflammation, rather small micro tears and tendon degenerations, which is causing this kind of a problem. So the peak incidence is between the 40 and 50 years of age. Most commonly, the dominant arm is involved. It's related to repetitive stress injuries and only 5 to 10% of these cases are tennis elbows. I'd rather call it housemaid's elbow. So it's usually self-limiting, but it can become chronic in 10 to 20% of cases lasting more than 12 months. The pathology here is mainly the problem is the degenerative disorder of the extensor carpi radialis brevis. The ECRB is most commonly affected and vulnerable because it lies deep and anterior. It experiences high tensile loads during movements, has relatively poor vascularity, and it's compressed against the capitulum during the elbow extension. In medial epicondylgia, it accounts for only 10 to 20% of all the epicondylar conditions. Again, 40 to 60 years of age group with both occupational and sports injuries. It presents as pain in the inside of your elbow, which worsens on wrist flexion and pronation. Many of them can have ulnar nerve symptoms also because it's a very close proximity in 20 to 50% of cases. Again, the risk of throwing sports, golf, racket sports also. Many times we see it in shuttle badminton players also. And coming to the more uncommon tendinopathies, which are the elbow, the triceps tendinopathy and distal biceps tendinopathy. So here you get in the triceps, it's pain in throwers, weightlifters, and those performing repetitive elbow extension activities. And pain, recently I had a person from the army who was doing playing a lot of volleyball, and he's doing a lot of push-ups and pull-ups, and he developed this kind of a olecranon pain, which was diagnosed as a triceps tendinopathy. Similarly, biceps muscle is getting attached to the bicipital tuberosity, the radial tuberosity. And here, in middle-aged males who do a lot of weightlifting in gym, I've seen a few of them who come with this kind of pain, where there's weakness in supination and flexion. There is a risk of rupture also in these cases. Now, coming to what are the pathophysiology of the tendinopathies here. In the normal tendon, the collagen fibers are well organized. It's got minimum cellularity and optimal mechanical properties. However, in reactive tendinopathy, there is a short-term adaptation to overload. There may be thickening, cell proliferation, potentially may be reversible also in a reactive state. In tendon disrepair, disorganized matrix, increased cellularity, vascular proliferation, these occur in the intermediate stage. But eventually, in a degenerative tendinopathy, the collagen disarray, cell death, focal necrosis, and limited healing potential occurs. So this is the entire gamut of the pathophysiology of tendinopathies. So what was initially thought as inflammation has gone on to a paradigm shift. There is absence of inflammatory cells in these chronic cases, so there is no chance of inflammation. There is a disorganized collagen architecture, increased ground substance and proteoglycans are seen on microscopy. There may be neovascularization and also some nerve ingrowth. This may be the reason for many people complaining of severe pain and neurotic kind of pain, which also radiates down to the muscle bulk also. There is apoptosis and cellular changes in the microscopic studies seen. Now, the clinical presentation is usually the pain which is activity related. It definitely improves with rest. Localized tenderness is there. Morning stiffness is also there. Most difficult problem for these people is functional impairment. Whenever they are gripping things, whenever they are housewives, when they are saying they are washing clothes, they are squeezing the clothes, or when they are washing utensils, or in that shuttle badminton players when they are smashing, all these people have severe pain. And the pain may be gradual in onset, and the progression will be gradual. Symptoms often present for months. Also, it can persist. Now, how to find out this condition by your basic inspection, palpation, and definitely you can feel the muscle tenderness over the lateral epicondyle or the medial epicondyle or either these points. The range of motion is assessed. And then there are special tests which are for each of these. The Cosen's test, where you resist wrist extension. The Mills test is a passive wrist flexion with the elbow extension. And the Modley's test, which is a resisted middle finger extension, are very good tests to find out about lateral epicondyle. Similarly, in the medial epicondylitis, the resist to wrist flexion, pronation test, palpation during wrist flexion, and of course, you have to assess the ulnar nerve also. Like I told you, there may be an involvement of the ulnar nerve in this condition also. You can also do grip strength using dynamometers, pinch strength testing, and functional task performing and record these things. What about imaging modalities? X-rays of limited value. You can see if there is any bony changes, cysts, calcification, this to rule out anything else. Ultrasound imaging is probably one of the first line imaging modality. However, you need to have a good radiologist trained in musculoskeletal radiology to give you a good report. The magnetic resonance imaging is the gold standard and it will give you exactly what the problem is. Always think about the differential diagnosis in all these conditions, radial tunnel syndrome, posterior pin involvement, adiocapitular arthritis, osteochondritis, all these things you have to think about in the lateral elbow pain, which is the most common. Other conditions include rheumatoid arthritis, intra-articular pathologies, and systemic inflammatory conditions. And referred pain from the shoulder or neck is one of the important things. I think the neck referred pain is most often confused here. So coming to the management of this condition, the conservative management is the mainstay for treatment here. So nearly 70 to 90%, if you do properly conservative management, they do much better. So the core principles are load management and activity modification. This can lead to progressive tendon loading exercises later. You may use orthotic supports or braces or splints, which we'll be talking about. Of course, pharmacological symptoms can be managed, pain management can be used, the drugs can be used. Patient education and expectation management is very important. I know many of the sports persons are really addicted to their sports, so it's very difficult to make them do the rest for this kind of, but it's very realistically we have to tell them. Here, initially, you have to, in the acute phase, you have to give rest for a couple of weeks. Then you start gradual physiotherapy and gradual range of motion exercises. Rehabilitation phase, I will not go into the depth of it. Dr. Iran is going to be talking about it. Then maintenance phase later. So in the protocols, again, like I told you, initial phase is only for pain management. We often use ultrasonic therapy, which is very good for this kind of tendinopathies. Strengthening phase, eccentric loading, and then functional training in the advanced phase, especially for sports people. Now, splinting options for elbow tendinopathies is a very good supportive role for your treatment. So it reduces the strain on the affected tendons and provides proprioceptive feedback to the patient. So again, allows continued activity with reduced pain. And also the grip strength may be improved because of these splints. And again, it also facilitates early return to function. The counterforce braces is most often used is used to distribute the forces across a broader area in the forearm musculature. So the concentrated loads on the epicondyle region origin is reduced. So this dampens the muscle vibrations and reduces the peak forces transmitted to the inflamed area, or sorry, the injured area. Clinical evidence suggests that they do improve the function in 70 to 80% of users. It's most effective when combined with physiotherapy and also some kind of pain reduction medicines. You need not wear it 24 hours. Use it during activities only. Usually it is applied on the belly of the muscle and not on the epicondyles. Usually 3 to 5 centimeters on the belly of the muscles is where you need to apply this. You can also use a wrist extension splint where the splint is kept in about 15 to 20 degrees of extension. This also can reduce the strain on the attachment of the lateral muscles. So here you can use it for acute lateral epicondylgia. It can be used as a nighttime splint and while during work also for some of these people. You may need to use it for 4 to 6 weeks and gradually wean it off. Other braces include compression sleeve, which, sorry. Yeah,
Yes, sir.
just a couple of more minutes. Yes. Compression sleeves, hinge braces, and immobilization splints. All this can also reduce the pain. Pharmacological NSAIDs, mostly in the acute phase. You can also use topical NSAIDs and also cold compress. So the limitation of pharmacological therapy is that it's only for pain management and also it may have a side effects. Then comes the injection therapies where you may use either steroids or platelet-rich plasma or stem cells. So here it's a very useful in recalcitrant cases when your conservative management fails for more than 6 to 8 weeks, then you may go in for this kind of injection. Corticosteroids, you can give it 2 or 3 times. If you can give it an ultrasound guided, it will be better. And the disadvantage is that sometimes you can have fat atrophy, skin depigmentation, and recurrence rate also is possibility. Platelet-rich plasma is now gaining popularity. It definitely, by delivering supraphysiological concentration of the growth factors, will help in healing those damaged tissues. I'll not go into the details of it, but the evidence points that in the short term, there is quite a lot of improvement. More than 3 people in 4 get a good result. And about you need to give 2 injections in 4 weeks gap. And extracorporeal shockwave therapy, probably our physical therapy will be dealing with it, but it also helps in neovascularization, stimulation of collagen production, breakdown of degenerative tissues. Stem cell therapy, I will not go into the depth of it. Still, it is the lot of theories have been put forward. It can have advantage. It may help, but still,
Satish,
yes.
Satish, we'll have to keep the schedule. We'll wrap up with soon.
Okay, sir. I'll just do the conclusion. So it is a multimodal conservative approach. Bracing and splinting may play an important role. Medications will provide symptomatic relief, and injection therapies for recalcitrant and surgery if nothing works. Thank you very much. Sorry to have taken a little more time.
Thank you, sir. Thank you for the elaborate, concise description of what all the options available for us now. And coming back to the next speaker, so this is Dr. Iran Rali from Guwahati. Yeah, and he's a AO man. So he's been the co-chair in AO principals course, and he heads the orthopedics department at Downtown Hospital in Guwahati. So his also interests are basically complex trauma, minimal invasive orthopedics, and orthogeriatrics and sports medicine. So over to you, sir, for the next talk. Thank you, sir.
Yeah, thank you so much. Let me share my. Well, good evening to all. After a very detailed presentation on a condition, tendinopathy around elbow, which is, it's very common in day-to-day practice. So when you talk about tendinopathy, we are talking about these 4 conditions basically in decreasing order of frequency. I think it's been dealt with already. So nowadays we consider them to be tendinopathy rather than tendinitis. So this is lateral epicondylar tendinopathy, medial epicondylar tendinopathies, distal biceps and distal tricep tendinopathies. So what about rehabilitation? I will strictly talk about rehabilitation part only here. So does it work? If it works, what can you expect from rehabilitation? And what you actually should do, when to do, and how to do. So these are the few questions that comes to your mind when you talk about rehabilitation. I'll in next 10, 20 minutes or 10, 15 minutes or so, I'll be touching few of these questions here. So the classical teaching or the traditional approach has been different than the modern approach. Classically, the philosophy was, we thought it to be tendinitis. So the traditional approach was to reduce inflammation and the pain. Okay. And when you talk about modern treatment, we talk about it is not just tendinitis, it is not just inflammation, it's already been dealt with. It is tendinopathy. There is some degenerative conditions around the tendon. So your philosophy is just to stimulate healing, structural remodeling of the tendon tissues. Sorry. Okay. The approach is, earlier we used to do passive treatment, rest, ice, meds, and splints. But now we go for active treatment. That is the exercises, and it's a multimodal approach, the loading exercises. Earlier, the exercise type was limited. We used to more go for the passive stretching and deep massages and all, and ultrasound and all. But now the focus is more on the progressive loading, the eccentric loading on the tendon, because it has been seen that the tendon do better when you give load to them. The key mechanism, classical approach was just to inflammation management. But in modern approach, the evidence-based approach has shown that it's a mechano-transduction, healing via load. So if you look at these slide, you understand that when it is in the reactive tendinopathy, that is where there is inflammation. If you give excessive load on that, then it goes to the next condition, that is tendon disrepair. But if you give optimized load, appropriate optimized load, tendons start to regenerate, starts to adapt. Then there is anatomical healing. And then when you do a strengthening exercise, it leads to clinical healing. But when there is excessive load from tendon disrepair, it goes into degenerative tendinopathy. Here also, if the stress is greater, then it goes into rupture. But if you can give an appropriate modified load onto the tendon, again, you can reverse it. It can go into the clinical healing. So that is the basis of these rehabilitation exercises. So when you plan a rehabilitation, the basic framework is like you have to educate the patient educations, tissue load management. You do go for progressive exercises, manual therapy. You do tapping and some supporting modalities. I'll touch each and everything a little bit. So when you talk about patient education, basically you utilize teaching, counseling, behavioral modification techniques to impact patients' knowledge and health behavior. So what you do, you ask the patient to avoid extremes of range of motions at repetitive elbows, wrist and hand movements, avoid lifting heavy weights, suggest task modifications. And for overall body's general health, you ask the patient to avoid smoking, fatty foods, or obesity management. These are also important factors when you start rehabilitation of these patients. You also address the psychological factors like distress, or some people have this kinesiophobia. So you need to address those part also. So the next part which comes is the tissue load management. That is the optimizing daily loads to reduce symptoms provocation while maintaining the tissue capacity. So you address the reactive tendinopathy through pain management measures and deloading. You use rest and cryotherapy. You can use this electrotherapy like low-level laser therapy, ultrasound, shockwave therapy. That has already been told that extracorporeal shockwave therapy. These are some of the measures that you can apply. Use splinting techniques and braces, and then you can do some activity modifications. Next comes your progressive exercises. So there is graduated loading exercises designed to restore tendon capacity, strength, and functional tolerance. These exercises, actually what it does is it remodels the tendon tissues, it re-educates the tendons, and leads to a healing of the tendons. So you have isometric exercises, you have eccentric exercises, you have concentric and eccentric exercises, and you have stretching exercises. Isometric exercises are used in the early stage of the treatment, known for inducing analgesic effect while maintaining the muscle tendon integrity. Eccentric exercises is actually the key focus is more on the eccentric exercises, most commonly used, highly effective for remodeling the tendon collagen. Then you go for concentric and eccentric exercises to restore muscle strength and overall function, and stretching exercises overall to increase the range of motion of the joint and make the tendon resistant to strain. Then you have manual therapy. These are adjunctive therapies to modulate pain and facilitate movement, support active rehabilitation rather than replacing it. So you have soft tissue mobilization in the form of deep friction massage or myofascial release. You have joint mobilization, this one maneuver, it's called Mulligan's movement with mobilization. There's one technique that is being used by physiotherapists to reduce the active give short-term relief to the patient. Then neural mobilization, sometimes radial nerve gliding and flossing are also used, but not very commonly used in tendinopathy around elbow. But when there are other symptoms where radial nerve is involved, you can go for neural mobilization as well. Tapping is also is a very common form of temporary external support to modify load, reduce symptoms, and enable continued functional activity, particularly used by the sports physiotherapists quite often. So it is it lifts the skin slightly, reduces pressure, and improves circulation. It supports muscles and joints without restricting the movement. It also promotes movement awareness, used in combination with other treatments. Then you have other supporting modalities in the form of laser therapy, low-level laser therapy. You have ultrasound therapy. You have shockwave, that is the extracorporeal shockwave therapy, and TENS. Out of these, the most popular is that extracorporeal shockwave therapy, which is being used very frequently by physiotherapists nowadays for tennis elbow. I think is better than laser therapy and ultrasound therapy in giving you prompt relief. Then you can also use TENS when you think that the area of pain distribution is little bigger than the localized, then you can use TENS as well. So the outcome measures, how do you measure? You have this patient-rated tennis elbow evaluation, that is PRT, DAS score, and you assess at baseline, and then you keep on assessing it when say after a few months again and again. So there are some stretching and strengthening exercises. I won't go into the details of it. There are a lot of stretching exercises. There are some strengthening exercises, isometric and isotonic exercises, which could be can be started early when it is in the stage of reactive tendinopathy. But what I want to talk about is the eccentric exercises, which are important, because it has been seen now that there is significant improvement in the DAS score and the VAS pain score compared to standard treatment when you apply this eccentric loading of these tendons. What it does, it helps remodeling the tendon collagen while strengthening the extensors, and it reduces pain. And this is done slowly in a very controlled manner by lowering weight. Actually strengthen the tendons while it lengthens also the tendon. So if you see, these are some of the examples of eccentric loading of the tennis elbow. That is the dumbbell wrist extension. What you do is that you allow the dumbbell to, you lower this dumbbell you go for wrist flexion, and then you just avoid the sudden drop, and then lowering it like a jerk movement, and that is what is the eccentric loading. You can also go for this Tyler's twist using flex bar. That is, again, another form of eccentric loading, which is very good, which is also very commonly used by the physiotherapist. And you also can use reverse wrist curl. So these are some of the eccentric exercises. There are a few more, which you can think of while going for rehabilitating tennis elbow. So if you look at the literature, you will find that then very conflicting evidence of using deep friction massage, the orthosis, ultrasound therapy, even the shockwave. Though it is very popular, there is not very hardcore evidence for using this. Nevertheless, it is being used very frequently. There are weak evidence against for soft tissue mobilization, even for KT taping and laser therapy and TENS, and moderate evidence for elbow mobilization and rigid taping. Nevertheless,
another 2 minutes, sir.
Okay, just a minute. It's Okay. So what you do, when you talk about rehab, you can talk about pain relief and initial loading. That is the activity modification, main pain management, isometric exercise, and stretching. Then phase 2, you go for progressive loading. That is the subacute and the subchronic condition where you start these eccentric exercises. That is the key focus. You go for concentric exercises, yeah, and you need, tailor this strengthening progression, and also pronation, supination, and finally grip strengthening. And in the last phase, that is the strengthening and functional return, you go for even for scapular and shoulder stabilization and functional training. So the outcome measures for medial epicondyle is similar like DASH scores or VAS scores, or this is numerical pain rating scales. You also use the grip strength through handhold dynamometer, and you assess this. For this medial epicondylitis also, the concept remains the same. Only thing that the group of muscles remains, and now it is different. It's the wrist flexor group, where you start with isometrics, then again eccentric and concentric exercises. Then you go for grip strengthening as well. So these are some of the exercises for your isotonic, isometric, and also this is reverse styler twist for your eccentric exercises. In distal biceps tendinopathy, the concept actually remains the same, but only that group of muscles keep on changing. The phase 1, you do activity modification. In phase 2, you go for progressive loading, that is eccentric, concentric exercises. Phase 3 is functional strengthening, and phase 4 is return to activity. So similarly, in distal triceps tendinopathy, where initially sometimes immobilization is necessary, because in triceps you keep on moving the elbow initially, it becomes too painful. So you have to limit that a little bit, and then limit the flexion up to 30 degrees in first 4 weeks, and then you start gradually mobilizing the elbow, and gradually starts this progressive strengthening exercises as you do in other cases. So finally, to conclude, now there has been a shift from traditional passive treatment towards the more active load-based tendon rehabilitation and education. Modern rehab allows for light, moderate pain during exercises, shifting away from no pain policy. Modern evidence suggests that rest is detrimental, so you stop resting. Actually, tendon requires load to heal. Exercise is the key. Eccentric or standing exercise is the gold standard. You cannot fit one shoes to all, so there need to be tailored protocols based on irritability and functional needs. And you also need to educate and look for ergonomics, address the home and workplace mechanisms to reduce recurrence. With this, I conclude, and thank you for your patient hearing.
Thanks a lot, sir. Thanks a lot for that crisp and clear presentation of the rehab. I think the overall protocol remains the same for all the muscle groups. And so can I start sharing, sir? Can you stop sharing your slides? Yeah, thank you, sir. So now coming to the final presentation here. So Ajit sir will be doing that. As you all know, Dr. Ajit is the head of trauma of Tejasvi Hospital in Mangalore, and he's a past president KOA and IA. He is also chairman for EO Trauma India. So now coming to the surgical management, over to you, Ajit sir. I'll start sharing the slides myself.
Yeah.
So I'll just start the other presentation, sir.
Yeah, thank you. I think a little bit of challenge we might have in terms of forwarding the slides, because you have the control. Sorry about that, because somehow there was a glitch here in loading it. So at the outset, thanks to Dr. Alex and Farmed for giving me this opportunity. My role is to talk about the surgical management, which is a situation that we rarely encounter. I think most tendinopathies around the elbow are managed conservatively. By and large, activity modification, rest, analgesics, physiotherapy, and rehabilitation are the way to go for any tendinopathies around the elbow, particularly the lateral and the medial epicondylitis that we commonly come across. Can I have the next slide, please? Yeah. So like I said, this is the last resort, and it's only in about probably 5 to 10% of the cases that we do this procedure. And also, where persistent conservative attempts at treatment have failed. And of course, like Dr. Satish Devdas mentioned, you have to rule out other causes before you embark on surgical intervention. Otherwise, it could be disastrous. Next slide again. Yeah. So basically, on the lateral side, coming to the lateral epicondylitis, uh, we have options of open surgery, which is the most common and which is the only ones that I have done. Uh, then there is this percutaneous tenotomy, and nowadays people are also doing arthroscopic release. Coming to the open procedure, most often we are dividing the extensor carpi radialis brevis, and then debriding the pathological tissue there that again was mentioned in the first talk, all the degenerate material, and making drill holes in the lateral epicondyle and then suturing it back. Some people talk about lengthening the extensor carpi radialis brevis, but what we generally do is expose the tendon, open it up, debride the unhealthy granulation or inflammatory, or there's no inflammation like it was mentioned, the degenerated tissue, and then make a few small drill holes either with K wires. You need not use a large drill bit. K wires would do, and then suture the tissue back. And then, of course, you need a phase of rest and slow rehabilitation to regain the function of that limb. Next slide, please. So, doing this procedure, open or percutaneous, we need to be aware of the anatomy around. And if you are very aggressive or very inattentive, you could end up with causing problems either with the lateral collateral ligament or even the radial nerve there. Okay, so we need to be aware of this. Next slide. Yeah. So Nerschel and Petrone are the people who describe the technique. You expose the area, you excise all the degenerated tissue, and then you decorticate the lateral epicondyle, or you make drill holes. And like I mentioned earlier, you repair the tendon. Next. So coming to the exposure, this is what has been described by Nerschel. Yeah. Again, another technique, very slightly different. The success rate in most of the publications is about 80 to 85%. And we need to be aware of all complications in operative intervention. Next. So, yeah, these are the publications that are there. Okay. Next. Yeah. So just an incision over the lateral epicondyle for about 2 to 3 centimeters, maybe a little longer. You expose the tendon of extensor carpi radialis brevis. You identify it, you expose it, you incise that, and you open it up. Next. Yeah. So these are all the steps in this particular thing. And you can, once you have exposed it like a book, you can curate out the unhealthy tissue and then make some drill holes and uh, uh, suture the tendon back and then close it up. Next. Yeah. So same thing being shown in another patient. Okay. So you can also needle it. Some people prefer to needle it. So that's how it is done. Okay. So next, coming to, of course, you need to rest these patients in a splint that was shown in the earlier one, and then advise graded exercise regime, stretching exercises like was shown by Dr. Iran, and then gradual regaining of their physical activities and normal work pattern. So that's important. Coming to the arthroscopic, the advantage is you are doing both diagnostic as well as treatment wise, both the diagnostic as well as treatment wise. So there is a learning curve and there is increased surgical time compared to open methods. You can, once you tease off the area there, you can visualize the tendon as you go further. See there, the tendon is visualized, and then you look at the consistency or the color and the unhealthy tissue, and then you sort of abrade it with the burr that you have, or radio frequency ablation also can be done. It depends on, yeah, there it is being done. This I have borrowed from my arthroscopy colleague from Manipal, Dr. Kiranacharya. They have done quite a few cases by this method. So this is how it is done. Okay, and there is a good or comparative outcome in as compared to the open procedures, about 85 to 87%, and they have followed in literature. This is average follow-up of about 130 months to in about 42 patients in that particular series by Baker and others. This video is from Dr. Kiranacharya that I mentioned. Next slide. Yeah. Okay, so that's the reference. So this is the percutaneous way to go about it. Many of us do it blindly. You make a nick and then you can needle it, take a wide bore needle, or you can take a 11 number blade and cut the tendinous portion of the extensor carpi radialis brevis. What you need to be aware of it is your wrist has to be steady and very minimal movement of your fingers. So, and the forearm has to be pronated and the wrist has to be in flexion so that you don't, you're away from the nerve, the posterior intraosseous nerve as it comes out. Okay. So you need to be careful about that. Can you click on the video? I think this is from the net. Yeah, it will play. This one is particularly done under ultrasonic ultrasound control. You can see the operator looking at that under local anesthesia. So in the OR, of course. Okay. The only thing is for the ultrasound, you have to put the gel there. So how much of sterility there is, that is a different issue. But the probe is of course covered with a sterile cover there. And then you make a small nick. Okay, the forearm is pronated and wrist should be flexed, just like you would do a percutaneous with a knife. Okay. So under vision. So the problem here is the operator, that is the orthopedic surgeon, has to be familiar with the ultrasound technique. So that's important. Otherwise, your radiology colleague will be doing the ultrasound scan and you would be performing the surgical part of it. So I've not had many of my colleagues talk about this, but definitely people are in every field going on to minimally invasive. So this is also one way. Next, same thing, I think. Next slide. Yeah. So coming to the medial side, same thing you do to the flexa carpi radialis and the pronata teres. Similar to the lateral, in the open procedure I'm talking about, the same sort of technique. You expose the area, curate out the degenerated area. If you want, make some small drill holes there, and then resuture the tendon, repair any defects. Okay, so this is much less performed, and I'm not come across any arthroscopic measures here, procedures here, because probably the ulnar nerve is very close and you could run into problems there. Next slide. Yeah, so same thing. So some people talk about the transposition of the ulnar nerve because they found that 60% of the cases have nerve entrapment. I'm not sure about this because that has to be a diagnosis done prior with nerve conduction studies. but this is what the literature says. And arthroscopy is very rarely performed by the real experts, I think. And the success rates are there, but the complications are also need to be kept in mind. Next slide. Yeah, so just to show the anatomy. So the flexor carpi ulnaris and the pronator teres. You can go horizontal or you can go longitudinal in your incision there on the tendinous origin. Next. Yeah, so for the biceps, very rare to intervene surgically. People talk about partial tear. I've not come across much literature, but most of the time when you do detect it clinically in weightlifters and bodybuilders, so to say, most of the time it is rest, ice, and analgesics. Very rarely we do infiltrate this also, but you need to be aware of the neurovascular structures around there. So it's a little tricky there. So rarely done. Most often it is conservative. Next. And I think triceps, very little information about that. So with this, I conclude my presentation. Thank you very much for the opportunity.
Thank you, sir. Thanks a lot for the detailed presentation of the surgical methods. It was indeed good to observe the arthroscopic and the videos of snapshots of the open repair. Now I think I'll give some scenarios, sir, like what can happen, what are the common things which we encounter in our clinical practice, so that all the can act, I mean, can all the speakers can just put to their word. Like there are one scenario wherein you have a 25-year-old active male who's a recreational athlete and develops a pain after like outer border of the elbow, lateral epicondylitis, and it usually starts for him after returning to sports after a gap of around 2 months. He was probably a badminton player and comes back. How do you treat this person? And a 40-year-old female, which is commonly seen in our OPD practice, mainly sedentary, and develops slow onset pain again, lateral epicondylitis, now present even on minimal stress, and occasional night pain also. So how do you go about these two different kinds of scenarios? So
Can I go, sir?
coming to
So
sir and
I
sir
think
and
the young active male has to be more of a training has to be done for him. So that's more of a rehab is what I would focus on for the young active male. And probably for the older lady, probably we should go for pain management first with some kind of physical therapy, and later on go for training. And she may need a steroid injection also at a later date.
May I interrupt, sir? Satish, sir, as you mentioned about the medical conditions and the comorbidities which are usually seen, and tendinopathy being a degenerative condition, a part of a metabolic syndrome nowadays, will you be doing some further investigations in a female who is 40-year-old, like any cholesterol levels or the hemoglobinopathy, I mean the sugar levels, thyroid levels? Will you do it in your routine practice? I'm just having this discussion because these are the common scenarios we get, and sometimes we overlook these conditions.
Yeah. Routinely, it would be just an X-ray in the beginning stages, and only when we are going in for probably a steroid injection, I would investigate other things. Of course, if she is a known comorbid conditions like hypothyroid, or I would always keep it at the back of my mind, diabetic.
Okay. Coming to Iran, sir, I mean, what is your plan on rehabilitating these two? What kind of exercises you want to give, or what kind of a counseling you want to give for these people? Two different kind of scenarios now.
Yeah. I feel that for the first one, that is the athlete one, we have to be a little aggressive on that part, and that needs immediate pain relief. So for that, I'll go for a multimodal approach. I'll start with pain management. We'll give medications along with some kind of modalities like either shockwave therapy or the ultrasound or the low-level therapy to immediate relief of pain and start off with immediate physiotherapy. That is, as I mentioned, we'll mostly go for the loading because he needs to return to activities much sooner than the other one. Probably this patient, this 25-year recreational athlete is in the reactive tendinopathy stage. It's just not gone into degenerative or tendon disrepair part. So in these situations, we can, if you rehab early, they're going to benefit much faster than just I'll never go for any kind of steroid injections or what do we call any kind of injections for that matter, PRP in the first scenario. The second scenario, yes, of course, we have mentioned a valid point of investigating these people. As I have mentioned, these are people. It could be a part of some uh, uh, immunological markers are much more in those patients, and they have got body pain, not only tennis elbow, they have other tendinopathies, anticipathies, So you need to rule out metabolic syndrome, as you rightly mentioned. So many of these situations, you have to not only to treat these tendinopathies, which are in mostly degenerative state. It's not too much of a pain, as you said, it's a slow onset pain, not very regular, comes present on minimal stress. So in those situations, I will again, mostly depend on the physiotherapy rather than going for any kind of, maybe at best I can think of giving a PRP injections, but then again, it will be reserved for those refractory cases which are not amenable. What I feel, tennis elbow is a condition can be treated only by physiotherapy. Rehab plays a very, very, very important role. But the classical teaching has been different. We used to give NSAIDs and then go for injections. If not, very rarely we give rehab. So rehab plays an important part. Yes.
Thank you, sir. But yeah, that's a perfect thing. I mean, both will need a rehab and the long run, and that will be the mainstay of treatment. We all agree with that. And also, especially in lateral epicondylitis, there has been recent evidence saying that proximal joint stability, basically in shoulder, in lateral epicondylitis, the shoulder cuff strengthening. I mean, those who are into sports medicine, basically, they would like to do that. And only concern will be, the 25-year-old male will understand that. Only question will be whether the 40-year-old female will be able to understand whether she needs wide shoulder exercises. Okay, but anyway, I think rehab is
most of these patients
educating.
also have rotator cuff tendinopathies. These old
Yes,
people.
sir. Yes, sir. Yes, sir. And
Can I
counseling. Yes,
just
sir.
come in?
Yes, sir.
Sorry. Yeah, a valid point that you brought out. In fact, Dr. Ashish Babulkar in Pune, he says he doesn't treat tennis elbow, he only rehabilitates the shoulders. He says because the shoulder muscles are weak, the elbows are being overloaded, and that is the cause. And I think one of his boys had done a thesis also on that. But probably there is some truth in that. I mean, I think we need to look into that as well.
And anyone who would like to also feel that cervical spine is the cause of chronic lateral epicondylopathy, I mean, pain, night pain especially, or numbness, or is it only the nerve regeneration as Satish sir highlighted in his talk, regenerative nerve endings causing the neuropathy, or do you feel also that cervical spine sometimes is at a fault? Any of the speakers, sir?
I think cervical spine, from my experience, most of the time, because of that pain, they tend to not use that shoulder so much, and they end up having like a frozen shoulder or
Yes, stiff shoulder and trapezius spasms, basically, like to lift the whole shoulder up rather than trying to, yes.
Yeah.
That is true. Yeah.
Yeah.
Some patients do tell you, I mean, but if you examine, you will find that it's not about tennis elbow. It is mostly actually originating from the cervical spine. And these radiculopathies needs to be distinguished from the actual lateral epicondylar tendinopathy.
Yeah.
Yes, sir.
Like
I mean,
said,
basically,
it is probably a differential diagnosis rather than a
Yeah.
cause.
yes, sir. Yes, sir. Correct, sir. And I mean, if at all numbness or neurological symptoms are more, there is an evidence to rule out the cubital tunnel syndrome and the radial tunnel syndrome in both these, like medial and lateral epicondylitis. Basically, you need to rule out the posterior interosseous nerve entrapment syndromes, which are also mimic like the elbow tendinopathy. But evidence and the differential diagnosis, when you try to see, the provocative tests will obviously rule it out. And sometimes, yes, nerve conduction studies will help us in deciding what is actually the cause, sir. And
Actually, it
Right.
was surprising. It was surprising to read that 60% of medial epicondylitis is associated with ulnar neuritis, and
Yes.
that particular paper has done a lot of ulnar anterior transposition of ulnar nerve. That
Ulnar
was
nerve,
really
okay.
surprising for me.
Okay, sir. Okay.
Can't hear you again.
Yeah, sorry. So
Back
these
again.
scenarios were basically for the lateral and medial epicondylitis, wherein you have a more muscle rather than the tendon at its origin. Now, coming to the scenario of the next slide, wherein of elbow pains, basically the triceps, and how do you manage these two people? A 25 or 35-year-old male, basically a sedentary person, comes in with episodes of pain and not into sports. These are sudden bursts of pain. Sometimes occasionally he doesn't correlate with anything. And a 25-year-old male, as I told you, a badminton player, a professional badminton player, started after a tournament, now 2 months and not able to play. So how do you manage these two patients, sir, now? I am trying to highlight the possibility in the first patient of having some metabolic problem. Whether will you go for that test? I mean, blood tests and all for the, like, usually in the first patient.
Yeah, in the first case scenario, I think because there is no aggravating factors like exercise or weightlifting or any repetitive stress injuries, you would have to do the entire investigations to find out why exactly he's got X-rays, blood tests, all the metabolic workup, and probably eventually, if there is nothing, then you may need to go for an MRI also.
Okay.
But the second, probably it is a repetitive stress injury. Again, these do well only with rest and training again.
Anything from the Iran, sir, like any rehabilitation, what you will plan on in the scenario on these two?
Second patient, I'll have to rule out tear. Sometimes, it leads to tear, triceps, a partial tear or intertendinous tear. So for that, I think I will go for an MRI to rule out any tear is there, which is not healing perhaps the way it should heal. And then since now it is 2 months not been able to play, I will not immobilize the patient. Again, if I see that there is not too much of a degeneration, just a tear, whether it needs surgery or it doesn't need surgery. If in 2 months' time it's still healing, probably I'll go for the rehab straight away. So there are many modalities that I have discussed. So that is the second patient. The first patient is again, we have to rule out all other conditions. That more likely, just tendinopathy, maybe a degenerative tendinopathy or a stress-related tendinopathy, or it could be due to some other metabolic causes. So that's ruled out, and then treatment remains more or less the same. Rehab as well as pain management. Rehab part I have already taken into account, which I have already. Yeah.
I just put this first patient scenario because it's actually a practical patient which was come to me, and I was treating him with some rehab medicines and exercises which he was not following because he was not an active person and he was not believing in rehab. And suddenly one fine day he comes with his friend and he says, "Sir, why not do uric acid testing?" I mean, I was surprised when he asked, and then we did a uric acid. It was very high for him, and I didn't add any febuxostat or allopurinol. Like, I just gave him colchicine. Prior to that, I was giving him NSAIDs. So colchicine definitely relieved his pain drastically. And then we went on to do a rehab. Once he was happy to, once the pain was relieved, he was ready to follow up our further advice. So I think that also matters sometimes. When initial pain relief is there, then they'll try to follow us more. And if we start only with exercises initially without relieving their pain, they may not follow up. And sometimes most of the patients will ask for some modalities like physiotherapy दे दीजिए sir, we want to do some physiotherapy, कुछ लिख दीजिए. And I feel that initial falling in pace with the patient tries to get his confidence in us. I mean, then he will follow with us. Otherwise, he will say, what this doctor is telling, no relief from 2 weeks, I'm going to him, nothing is happening. I mean, that is what practically I felt.
Yeah, true, very true.
And the second one, as you said, it's a standard person. I mean, nothing specific. As you said, I think imaging is very important because since he's a professional player, we can't delay his treatment because he needs to return to sports. And if it is a definitive tear or only tendinopathy, then we can plan for a treatment. I feel that especially in professional people, going for MRI early would be better for them to understand, especially when they are losing their time in their career. That was the highlighting point, sir. I think now we'll go.
You're muted again.
You're muted.
I'll just go for the question, sir. I'm just. Yeah, as of now, people are asking, basically, are there any role of long-term medications? I mean, that is one question they have asked. Any long-term medications or?
In fact, anti-inflammatories are not recommended for long term. It may cause difficulty in healing also. So I think long-term medications are still not. These things about collagen and other nutraceutical supplements have probably a role, but still evidence is not very clear on these things. So we cannot comment on long-term nutraceuticals. However,
Okay,
yes, that's it.
Any other like definitive role of any vitamin supplements you want to add particularly, or nutraceuticals will be okay in case someone wants to add?
No, vitamins are always good for tissue healing. Particularly vitamin C is always good for tissue healing. And along with that, the nutraceuticals are probably the way to go.
Okay, sir.
Yeah. We can add these antioxidants and vitamins along with, and particularly patients with this one group we have always been separated. No, in those group probably yes. Young people probably yeah. It is not that done. And then long-term medication definitely is not needed. It is mostly a self-limiting disease. So if you don't treat also by 6 to 12 months time, it's going to go down anyway. Only thing we need to manage it initially. That is what we need to do. Long-term, definitely, don't need any medications.
So another question is, okay, sir. That I think is okay, sir. Any other question is, when you want to give do the first intervention, like yourself, you want to do the first intervention, patient is being followed up with you, lateral epicondylitis. That's what I think they want to know. When do you want to give the injection? So I'm less putting it as when you want to do the first intervention, like patient is following up with you regularly. So Iran sir, like when will you start any injections if you want to go? Sati, open to all the panelists basically.
Okay, as for me, I prefer not to give injections, whether it is a corticosteroids or PRP. It is my last resort. If there is no relief at all after 3 months or 4 months of therapy, it's not. I always counsel my patients. See, you have patients, you do rehab, you do physiotherapy, you're going to do all right. I can give you injections, you will get good relief, but these are very temporary. If you don't do exercise, it's going to come back again. And also steroid, maybe it's give you short-term relief, but long-term, it does not give you that much of a benefit. So I give them the option of PRP, but then again, I tell them, even if you don't take it, it's going to go fine. But some patients are always there. Then they want some kind of intervention. That those are the patients probably after about 3 months or so, if I see that there's absolutely no improvement, even after doing physiotherapy, I'll consider some kind of intervention. Yes.
Thank you, sir. And one question is rehab important? Yes, rehab is as you said, it's the mainstay of treatment. I think injections will fall as a supplementary thing, neoadjuvant therapies like how we do it. And nothing specific, sir. I think, sir, over to Alex, sir. Sir, anything?
Yeah, thank you. Thank you to all the speakers. I think very interesting, and I think you covered all aspects of it. And I'm sure it has been useful especially to our young surgeons and to the PG students. So thank you, Ajit, thank you, Iran, and thank you, Satish, and thank you, Santosh, for an excellent moderation. So once again, before we close, on behalf of the HPI, I want to thank all of you for, I think, it's a varied and valuable experience. And again, to Santosh for conducting the session so effectively. Thank you to all the participants who joined us. I think the questions and the discussions is what makes these discussions meaningful and also successful. Once again, our appreciation to Farmed for supporting this series. A special acknowledgement to Saurav and team from Farmed, and to my colleague Shadrach from HPI. There is a lot of behind-the-scenes coordination. Thank you.
Thank you, Doctor. Thank you.
Thank you, sir, for giving us the opportunity. And thank you, Farmed.
Thank you.
And we look forward
Thanks a
from
lot.
this webinar. We are looking at probably on tendinopathies around the wrist and hand, probably in the next 6 weeks. And we look forward to having all of you and hope to see you all. Thank you once again. And
Thank you, sir.
Thank you.
Thank
Thank
you.
you.
and
Thank
good
you,
night.
everyone. Thank you, Ajit, sir. Thank you.
Yeah,
Thank you, everyone.
Thank you to
Right.
the
Bye-bye.
listeners
sir.
also.
Thank
Thank you for having patiently listening to us. Thank you.
Bye.
Good night.
Good
Thank
night.
you.
Good night. Good night.
Good night.
Next.